Veno-occlusive disease, or VOD, is a rare but potentially life-threatening complication of stem cell transplantation. VOD most frequently occurs in the first 3 to 4 weeks following stem cell transplantation, but can be seen later. It's characterized by ascites, a painfully enlarged liver, jaundice due to raised bilirubin, unexplained weight gain, and right upper quadrant pain. The initial trigger for VOD is thought to be damage to the sinusoidal endothelium, leading to initiation of pro-inflammatory, procoagulant and hypofibrinolytic state. Damage to the sinusoid can be caused by chemotherapy drugs, with or without radiotherapy, used in the conditioning regimen prior to stem cell transplantation. The hepatic metabolism of chemotherapy drugs produces several toxic metabolites, which are converted to non-toxic metabolites by the glutathione pathway in the hepatocytes. When this process occurs in patients with reduced glutathione activity, due either to pre-existing liver disease or to the action of chemotherapy drugs that reduce glutathione levels, toxic metabolites are not broken down. This results in damage to the hepatocytes and activation of endothelial cells. Activated endothelial cells begin to secrete proteins such as matrix metalloproteinase 9 and heparinase that digest the extracellular matrix, resulting in the loss of cytoskeletal architecture and the rounding up of endothelial cells. This makes the gaps between the endothelial cells larger. Red blood cells begin to migrate into the space of Dis, and the sinusoidal lining begins to dissect off. Activated endothelial cells also release cytokines and chemokines into the bloodstream that trigger an inflammatory response. Resident Kupffer cells are activated and leukocytes are recruited to the sinusoids. Activated Kupffer cells and leukocytes release more cytokines, leading to the appearance of adhesion molecules, such as ICAM1 and VCAM1, on the surface of endothelial cells. Leukocytes adhere to and roll along the endothelial cell surface, gradually slowing down. The increased porosity of the endothelial cell layer means that leukocytes move easily into the space of Dis. Activated Kupffer cells and leukocytes release more cytokines, leading to further endothelial cell and hepatocyte damage and sloughing off of endothelial cells into the sinusoid. As with any damaged endothelial layer, the normal response is to repair the damage by activating the coagulation pathway. VOD is associated with a procoagulant state. Coagulation factors normally circulate in the blood in an inactive form. Tissue factor is the major activator of the extrinsic coagulation pathway. Activated endothelial cells express tissue factor on their surface, where it forms a complex with factor VII. This complex catalyzes the conversion of the inactive protease factor X into the active protease factor Xa. Factor Xa binds to its cofactor 5A, which catalyzes the conversion of prothrombin to active thrombin. Thrombin then cleaves fibrinogen to form active fibrin. Fibrin molecules form a mesh over the site of damage, and platelets help seal this clot. Red blood cells and other cellular debris are trapped in the fibrin mesh, eventually leading to clotting of the entire sinusoid. Normally, the fibrin mesh gets broken down by plasmin in a process called fibrinolysis. Here, tissue plasminogen activator, released from endothelial cells, cleaves plasminogen to form active plasmin. Plasmin then cuts fibrin into pieces, and the clot dissolves. During VOD, however, activated endothelial cells release plasminogen activator inhibitor 1, which inhibits plasmin and thus prevents the clot from being broken down. Activation of stellate cells in response to endothelial cell damage is also seen during VOD. Release of cytokines from damaged endothelial cells triggers activation of stellate cells to contractile myofibroblasts and subsequent release of collagen into the space of Dis, resulting in fibrosis of the sinusoid. Overall, the pathogenesis of VOD is complex. VOD is associated with a pro-inflammatory, pro-coagulant and hypofibrinolytic state, eventually leading to fibrosis and complete obstruction of the sinusoid. Ultimately, this leads to liver failure, multi-organ failure, and death. VOD occurs in 8 to 14% of patients following stem cell transplantation, with a higher incidence in certain high-risk groups. Severe VOD can be fatal in more than 80% of cases. Despite this high mortality rate, there are currently no approved targeted therapies for the treatment and prevention of VOD. There remains a need for new drugs that can improve the outcome for patients with VOD.